So I'm going to talk about mechanisms of change in transference-focused psychotherapy. And I did want to just make one comment about mechanisms of change before starting to talk about TFP in general, and this sort of relates to a comment Barbara made at the beginning. I try to think about mechanisms actually at three levels. One, Carlos talked about explicitly, although didn't necessarily articulate it this way, but that is, what is the developmental psychopathology of the disorder, and how does the putative mechanisms within your theory relate to the developmental psychopathology? And Alan Kasdan, in a nice paper in American Psychologist talking about child psychotherapy, had made this argument very nicely. And I think that Kernberg and Linehan, in particular, early on, actually modified cognitive behavioral and psychodynamic treatments, paying attention to the developmental psychopathology of those disorders, and certainly others have too. And then I do like to think about, as Barbara sort of said, what happens in the person, what changes in the person, and also then finally, as Barbara sort of pointed out, that she thought I would be interested in. I think it was a good inference, high reflective function there. There was Barbara. I also do care about what is the therapist doing that affects the change in the patient, and that should be related to the developmental psychopathology. So I'm not going to talk a lot about what transference-focused psychotherapy is. Many of you are familiar with it. People have heard reference to it today. Mary, earlier in the morning when presenting about treatments for borderline personality disorder, pointed out that it's one of the what I would call the big five psychotherapies for treating borderline personality disorder. There's actually others that have evidence in randomized controlled trials, but I think that TFP, DBT, mentalization-based therapy, GPM, whether it's good or general, and schema-focused psychotherapy are generally considered the big five. What are the goals of transference-focused psychotherapy? Well, there are broad goals and there are narrow goals. And the broad goals have to do with better behavioral control, intimate and gratifying interpersonal relationships, the ability to achieve life goals, and those life goals, we believe, should be consistent with the person's interest and capacities. So ultimately, we want people to be doing the kind of things that they're capable of doing. Sometimes that doesn't happen right away, but certainly we believe everyone has the right to sort of make those, to pursue those. And then in terms of more specific goals, we're interested in decreasing suicidality, decreasing parasuicidality, impulsive hostility, angry outburst. And we believe that in doing this, focusing on these goals, it keeps people out of the hospital, out of the emergency room, et cetera. And then that sort of actually helps with interpersonal relationships and so forth. And we believe that this happens through the integration of disparate and incoherent internal mental representations of self and others, what people have called identity or object relations, and I'll talk a bit more about that as I go on. In listening to the presentations thus far, I thought the developmental models that have been proposed are actually similar to the model that we propose in a lot of ways, but I think it's a matter of emphasis in terms of what areas of those developmental models people are putting focus on. So most of the models are pretty consistent. They hypothesize that there's a constitutional factor in interaction with environmental factors, and depending on the ratio of those constitutional and environmental factors, people are more or less likely to be vulnerable to the development of borderline personality disorder. And at least in a mentalization-based approach, there's certainly acknowledgement of what we think is most central from a transference-focused psychotherapy model, which is representations of self and others, and their level of differentiation, integration, what we would call identity. And we think that this leads these problems in how patients think about themselves and others. And I think it's highly related to what Carla was saying in terms of mentalization, but we focus more on the representational part of it. I think when I think of mentalization, I think of it almost like an ego function. And when I think about what we're talking about, I think we're talking about the representational part of development. And we believe that the affect dysregulation that you see in borderline patients, the suicidality, the lability, is related to these difficulties with representations of self and others. And so that's the developmental component of it. What do we think needs to change in the patient? We want the patient to develop a more integrated sense of themselves, a more integrated sense of others. We believe that when that happens, the patient is able to experience emotions in a more rich and modulated way. And I was thinking as Lois was presenting, when Lois was talking about the vacillations that you see in the patients, we believe that those vacillations actually occur due to these unintegrated representations of self and others. So we believe that it's not simply you feel as if you're being abandoned or alone. We believe the person's susceptible to feeling alone because they're identity diffuse. And if they were more identity integrated, they would actually not necessarily feel as alone in some of these situations. So for instance, with borderline patients, when they get into a fight with someone, they feel like it's the end of the world, as if the relationship's over and they'll never, and that everything's disrupted and it will never get better. Whereas people who are integrated recognize that when they get into a fight with another person, that they can remember that they love this person, the person loves them, they've gotten into fights before, they have the script for what happens that people make up, etc. It's not the end of the world. Well, that happens with being identity consolidated or having integrated representations of self and others, and that's what we believe has to be impacted. And when that happens, the patient is then able to think more flexibly and benevolently. They are able to take in new experiences and learn from those experiences. Their relationships are infused with less aggression, greater capacity for intimacy, increased sense of coherence and identity, and better general functioning. And what does the therapist do to affect that change in the patient? So we believe that what the therapist does in the therapy room is actually provide a holding environment by being steady in their capacity to sit with the patient as the patient is experiencing the difficulties that they do, and to take an observing perspective on it. What Fonagy used to call an inquisitive stance. I noticed that you had a different name for the stance now. You called it a I'm forgetting what you called it exactly. Not knowing stance, yeah, not knowing stance, but an inquisitive stance, or what Roy Schaefer used to call an analytic stance. This idea that you're curious about what's going on for yourself and how to understand it, and you can consider it, and you don't have to engage in what Mary made reference to earlier today, this experiential avoidance. Because experiential avoidance isn't just a behavioral concept in terms of you don't do things. If you read what Stephen Hayes has written about it, he talks about it very much like a defense mechanism, a la George Vaillant. He actually compares it to splitting in his early writings about experiential avoidance. It's about avoiding thinking about things that you find intolerable. And so this is, what we're hoping to help the patient be able to do by sitting in the room with them, tolerating ourselves, observing it, bringing the disparate aspects of their experience into their awareness. Now, in doing this, we have certain mechanisms that we tend to focus on. Frank Yeomans, Eve Callagher, and I wrote a paper for psychotherapy where they asked us to focus on only 3 mechanisms and the empirical evidence for those 3 mechanisms. We talked about setting the frame. This is done, as I say here, collaboratively with the patient. You don't absolve your professional responsibility in doing this. If you don't agree with the patient, you may not be able to come to an agreement for treatment, but you have to do this collaboratively. You can't impose the frame on the patient. But it's important to explicate the frame with the patient and to develop the frame, because often these things, particularly in identity-diffuse people, are not necessarily readily available to them. We take a non-judgmental stance, what we typically call in TFP technical neutrality. I don't like to use the term much anymore because I find that it's confusing to people. They think about neutrality in the old sense of the word. Used in psychoanalysis, they think of sort of bland or aloof therapist. Kernberg actually called it tech neutrality to distinguish it from that, but I don't think it's necessarily succeeded. And I realize that really all we're talking about is taking a non-judgmental stance with the patient in order to allow material to come up. So if you don't side with one side of the conflict, then the patient can bring that material up. If you do, you're cutting off those avenues. And so this is a stance that we take, or an attitude that we have. And then we pay attention to the channels of communication, what is said, the affect on the patient, their behavior, and what's evoked in you as sitting across from the person. And we use that as a barometer for what might be happening. There's complicated aspects to that too. But I'll actually give an example of this. Recently, as part of a supervision group, patient comes into session and says to the therapist, sorry about my odor. I haven't showered in a week. And as the patient sits down, then looks at the therapist and has a giant smile on his face. And so we would take note of that and bring that up in order to explore what that might actually be about, to help integrate what might be going on. In this case, what came up rather quickly was that there was a part of the patient that actually wanted to sort of essentially say to the therapist, you don't know what you're doing. I'm still sick. I can't get out of bed. And I hope my odor doesn't offend you too much, but actually I do. And so we pay attention to the affect, what's said, their behavior, et cetera, and what's evoked in us. And then finally, we engage in an interpretive process, which is actually quite involved. I'll just go into some brief aspects of it. So in the interpretive process, it's not simply about the interpretation. It's often about the setup of the interpretation. It starts with clarifications. And this is an extremely important part of the interpretive process. I'm constantly saying to my students, clarify, clarify, clarify. You have to spend your time clarifying so that you understand what the patient's experience is. And because you assume, patient says, I'm depressed. We all know what the word depressed means. And so we think we know, and therefore we assume, but they may mean something different by it, and we need to clarify those things. Confrontation, not necessarily the best word here. Trying to find a different way of actually stating this, but simply all a confrontation is bringing into the awareness, into the patient's awareness, aspects of their experience that are disparate. You have to do this gently. You can't do this in a way that feels harsh to the patient. It has to be done gently. And then finally, the transference interpretation also has to be done in a timely, tactful way. But and this is done in the here and now of the experience that the patient and the therapist are having in the room, because that's something you actually are there for and know about, and you can actually do something about. Okay, I'm going to skip this slide. Uli given me the 2-minute mark. I noticed that all the speakers are talking fast. We had talked about trying to keep our talks short so that we would have time to discuss among all of us, and you guys, and so I'll skip for this reason. What does the research show? I'm just going to go into a couple of minutes of the research. Well, we think identity is important, and we have some basic research that's in press now, and a special issue that Uli is actually the editor of, went out for peer review nonetheless, where we were actually able to show that identity is an important aspect of thinking about self-injurious urges. So we looked at self-injurious urges in a smartphone study where we looked at people over 21 days, both event contingent assessments and random assessments, and we looked at their ratings of affect regulation as it related to their urges. This is in borderline patients and patients with anxiety disorders. And what we found was that affect regulation was indeed related to urges to engage in self-injurious behaviors, but only in the context of when the person felt that they were identity diffuse. And it makes sense if conceptually, lots of people are affectively dysregulated. They don't go around cutting themselves. But when you're affectively dysregulated in the context of identity diffusion, then it seems like a viable option. Okay, that's just the point I just gave here. We also have in our randomized controlled trial showing evidence that we can change a construct that we see as a proxy for identity, reflective function, and attachment representations as measured on the AAI, and that's been published a number of years ago, which again is related to Barbara's point, is actually about what changes in the patient. We have that evidence too. We've been able to show that these constructs relate to processes that occur in the psychotherapy, such as alliance and dropout. And we've been able to show that, that these mental state vacillations that are characteristic of identity disturbance actually mediate the relationship between neurocognitive functioning in terms of effortful controls, a construct we heard talked about in Harold's, Konigsberg's talk, and the alliance. So the relationship between effortful control and the alliance was actually mediated by mental state vacillations as a proxy for identity. The last piece of evidence that I'll actually talk about has to do with a recent study that we published looking at brain changes in patients in treatment for with TFP, and showing that actually we can show brain changes in TFP2. So this is, I think, similar to what Barbara had shared about Marianne Goodman's work in DBT. There are more next steps. I won't go into, how am I doing on time? I'll just, these are the next steps as I see it. More work to be done. As I think Barbara said, this work is not easy. There's a lot of statistical issues involved, a lot of conceptual design issues involved, and certainly the work that we have is only the very beginning of actually showing the mechanisms are operative as hypothesized, and these are some of the things that we need to do in the future. And I think I will end here. So thank you.